Right, good afternoon, everyone. I'm going to start the meeting, if that's okay. A couple of minutes late. We've got over 40 people joined us so far and more coming. And welcome this afternoon to the first in a series of clinical learning events. So this is our first of 6 monthly events where the format will be a keynote presentation and a poster or abstract style presentation featuring some of the case studies that were in the Modern Ward Rounds guidance, and then we'll open up the floor to a question and answer session with a clinical reference group who we have a multi-professional group of experts within the Ward Round guidance and within their field who will be able to have a panel discussion. We very much hope that this will be guided by you, so please do put your questions to the panel in the chat box, and we will curate those and hopefully get some debate. So before we start, a couple of housekeeping rules. We are recording the session for those who can't join us, and it will be available on our NHS Futures platform. If you haven't been able to get access to the Futures platform yet, please do so by replying to general email a box where the communications come from, and we will sort that out for you. I'm delighted to say that we've got 216 delegates working in the collaborative at the moment, which is a huge number and a great achievement. So thank you for everyone who's joined up so far. If you're not speaking, please do keep your microphone on mute. And just to start, if everyone could put their cameras on and give each other a big virtual wave, I think that'd be quite nice. So if we give each other a wave, cameras on, and just wave to each other, that's great. Thank you very much. Nick Roper put a physical hand up or virtual hand up in the box. Thank you very much, Nick. So this afternoon, I'm delighted to be joined by 2 presenters. One is Emma Stockton, who's a paediatric anaesthetist from Great Ormond Street, who's going to give us a talk about healthcare design. Emma and I met at a conference, a virtual conference last week, and I'm delighted that she's been able to join us for the learning event today. And we're then going to hear from Zubair, who's a fellow gastroenterologist down at Yeovil, who's done some great work on ward rounds involving reducing noise and the effect that's had. So Zubair will be presenting that, and then we'll open it up to the clinical reference group. Before we do that, can I just introduce the clinical reference group? So if everyone turns their cameras off apart from the clinical reference group. That's great, and I'll just get people to introduce themselves. Nikki, can we start with you, if that's okay?
Hi, thank you, Andrew. My name's Nikki Ashby, and I'm the Head of Practice Learning and Development at the Royal College of Nursing and co-chair for the Modern Ward Rounds document.
Thanks, Nikki, that's great. Lynn?
Hello everyone, I'm Lynn Quinney. I'm a member of the Royal College of Physicians Patient and Carer Network and have been involved in this work since the outset.
Thanks, Lynn, that's great. Ros?
I'll be up in a second.
Don't know if Ros is with us yet. That's fine. David?
I am David Campbell. I'm a Chief Pharmacist and Clinical Director for Medicines Optimisation in Northumbria Foundation Trust. Here at the, well, I volunteered on behalf of the Royal Pharmaceutical Society to support pharmacy in this work.
Lovely. Thank you very much, David. Pedro?
Good afternoon, everyone. My name is Pedro. I'm pharmacist at Practice Plus Group. Also, such as David, I'm a pharmacist, so I'm here on behalf of the Royal Pharmaceutical Society to provide my input to this group. Thank you, everyone.
Lovely. Thank you very much, Pedro. And Gordon?
I'm Gordon Calder. I'm a consultant physician up on the west coast of Scotland in Oban, and started doing some quality improvement work on ward rounds probably as long ago as 2004. Really interested today to hear Zubair talking about the noise on ward rounds. I did an audit on ward rounds, and our chief executive switched off the bedside phones and the televisions and changed the cleaning schedule when I did that audit. And great to see David here as well, because I don't know if Nicola's been to Northumbria and seen the Cramlington Hospital, which I think is the best designed hospital I've ever seen. It's fabulous.
Fantastic. Thank you very much, Gordon. That's great to have you with us. Now, before we start with Emma's presentation, if that's okay, we've got a quick Mentimeter. Just want a quick straw poll of everyone on the call today. I'll pass you over to Nick, if that's okay. Thanks, Nick.
Thanks, Andrew. So yeah, just a real quick session on Mentimeter, just get a bit of feedback from your thoughts at the moment. So any of you who used Mentimeter in the past, for those who haven't, please get your phones out, turn the camera on and just scan the QR code on your phones. If you're using a PC or separate PC, go to mentimeter.com and use the code 40938536. So once you're all logged on, I'll see you at the bottom corner here and see you all starting to log on. If you can just click the yeah, that's great. We've got plenty of people logging in now. I'll give you all a chance, a few seconds just to get logged in. There'll be a few. I think we've got 4 questions, just very quick questions to ask. We'll spend a few seconds. Put my teeth in. A few seconds on each question, and then we'll be able to hand that information back to the clinical reference group for the panel later on. Okay, so I'm going to move us on to our first question. Hopefully you're all logged in now. The first question I want to ask you, it's a pretty straightforward question, yes or no. How many of you would like to improve your ward environment? So pretty unanimous at the moment. Nobody out there that thinks it's all great. 32 up to 33. We've got 55 people on the call today, so I'm looking for those kind of numbers in responses. Again, still unanimous. There's still nobody out there that is loving their ward environment. So this is all great news because you're going to hear a lot of appropriate content, I guess. Okay, so going to move us on to the next one. Next question we asked is, please rate on a scale of 1 to 9. What's your ward environment like for delivering ward rounds in particular? Is it from 1 to 9, 1 being least suitable and 9 being most suitable? Select where you sit with regard to your organisation. Okay, nice and middle-ish at the moment. How very British, sort of in the middle. Okay, just 5 at the moment, so it's just a little bit over the average. Over the middle, yeah. So we, you know, there's elements I guess that we're okay with, but I guess there's still plenty of room for improvement. So these are the kind of things that I think we should be sort of maybe exploring a bit more detail a bit later on with the panel. So keep those thoughts in mind, or maybe put your questions in the chat box if you've got any queries around that. Okay, so next question. This is going to be a word cloud. So what things would improve your ward environment the most? So think about the environment that you work. What is it that that you think would have the most impact? We should start to see some words popping up on the screen in a minute, if it's working right. Well, there we go. Okay, we've got space, big one, space, more space, still space. Yeah, excellent. Quiet, less interruptions. Brilliant. Yeah, that's it. That's kind of what we'd expect, isn't it? Rules a bit tight for space. Technology is another big thing. Absolutely. Workstation on wheels. Less people. Yeah. Feel a bit cluttered. I think, as Gordon touched on a minute ago, how do you coordinate your ward rounds with other activity on the ward? So, for example, you haven't got a cleaning schedule, which means that the cleaning schedule coincides with the ward round, perhaps. Excellent. So we've got a load of responses to this one. Thank you for that. And then, so I'm going to move us on to the next one. I'll share all these with you after the session. So just simply from this session, what do you hope to gain from today's event? What is it that's brought you to this session today? And this may give a little steer to Zubair and Emma. Great, yeah. So able to contribute. Obviously, there's get a chance to answer your questions. We'll have that discussion on the panel later on. Best practice, I think you'll definitely hear a bit of that. Lots of ideas, practical tips. Yeah, I think it's taking the theory into practice, isn't it? About how can we convert some of the, particularly if you've got an older estate, I suppose. How do you convert that into practice? Okay, a few more seconds on this one. I think that's the last one for this session. We have one more question we'll ask at the end of the session today. A few more coming in. Still more good practice. Patient flow sharing ideas. Just lots of ideas, I guess. So you've all joined today predominantly. You want lots of ideas. So no pressure, Zubair and Emma. Everyone wants lots of ideas to change their ward environment. Okay, so I think that's wrapping that one up. Okay, thank you very much for contributing. Andrew, back to you.
Thank you very much, Nick, and thank you, everyone. That's really fantastic, really helpful for us. I'm gonna, in the interest of time, I'm gonna hand straight over to Emma. And we've already forwarded a bio of Emma, so I'm not going to introduce her any further than that. But thank you very much, Emma. We're really looking forward to hearing your presentation. Thank you.
Andrew, thank you very much. Can you hear me okay?
Absolutely fine.
Great. Brilliant. Well, thank you very much for asking me to talk today. It's not very often that I get to talk to loads of people from medical specialties. I'm normally surrounded by anaesthetists and surgeons, but I wanted just to say thank you very much, and it's a really, really exciting opportunity for me, and I hope that I'll be able to address some of those things on your last Mentimeter slide. So because I've got like a captive audience, I'm going to talk about me for the first bit of this talk. So I'm an anaesthetist, and you might think, like, what do I know about ward rounds? And actually, you would be correct. I don't know anything about ward rounds at all. I've read through all your documents, and I was kind of interested to see that they're not supposed to last longer than 150 minutes, which I thought was quite a long time. But the reason I'm interested in healthcare design is about 8 years ago, I turned up for my list. We start a bit earlier than physicians, so it was about 8 o'clock in the morning. I'd seen the patients. I was a bit stressed about the rest of my interventional radiology list, but I turned up, and on the bed in the IR suite was a load of plans and some designers standing around and the rest of the team. And they said, right, can you have a look at these? We need to get sign off on them because we're building a new lab. And we just need you to have a look at them and tell us that they're okay, and we'll just sign it off. And I looked at them, and I haven't got a particularly good 3D spatial awareness, and I couldn't make head or tail of them because IR labs are complex. There's stuff hanging off the ceiling, there's stuff coming out of the floor. It's difficult. And I knew that they had tech in that lab in 2012 that could mock up a kidney in 15 seconds in really good 3D detail. And I also knew that IKEA had a kitchen planner that could do the same. And so anyway, they kind of went away. I started my list, and I was feeling really agitated because this has been a really unsatisfactory interaction. So I went to see the woman who was the head architect at Great Ormond Street at the time, and I said, I'm very cross about this because you want our input, but yet you don't want our input. And she said, well, you're absolutely right, Emma. We definitely can't do 3D mock-up. It would put the program behind. It would delay everything. It would cost too much. But don't be cross. Why don't you do a master's in planning buildings for health? So I went off and I did my master's, and they built the labs, which I now work in, which are not ergonomic, to put it mildly. And my master's was really good, and we did a dissertation looking into why clinicians' voices weren't really heard in building projects. And there were quite a few reasons, but the ones that came out that I thought I could do something about, one of them was that clinicians need a bit of education around the process. So many of you will have been involved in small projects, maybe ward refurbishments or larger projects, and you may or may not have felt you've got your voice heard. But there isn't really, often a lot of jargon will be used at the table, and there'll be a huge pressure to get things done. We can't delay it. We've got to get on. We've just got to get on. You know, there'll be the business case has got to go through, and the costs are going to rise exponentially. Cost of construction, all this stuff that you can't quite fight back against. So with some colleagues from my course and some architects, we set up a course called Building Blocks for Clinicians, which has had very good feedback. We run it twice a year, and I can send you all the details, and I would really love it if we had some physicians on it, because normally we have a lot of anaesthetists because I advertise it. So this is a little plug, but it's really good, and it was a start. So the other thing I found in my research was that this isn't a problem that wasn't unique to Great Ormond Street or London or England. It's a sort of worldwide problem, that there's this kind of tension for clinicians between building projects, which are long-term, looking to the future, being strategic, and patient care. And I read, and I think you're all probably feeling in your ward rounds, and the fact, you're here, but some of you have got to, I think Gordon's got to go off to because he's on call. We've all got this kind of constant tension that we want to do one thing, but we're doing another. And then so we substitute someone else to go into a meeting, but what you don't then get is the continuity of care. So with this in mind, I tried for quite a long time to get traction at Great Ormond Street to have more clinical time for building projects, and I couldn't really get it. But we're very luckily funded. A lot of our stuff is funded by a charity, and the charity, interestingly, couldn't really understand what they were paying for. They would fund buildings, but they didn't understand how they'd fundamentally revolutionise patient care. And so the charity agreed with me that we could give a little bit of funding to backfill clinicians to take on that role. So we're building a new children's cancer centre, which is in some ways not relevant to what you guys are doing, but I think there are a lot of parallels, and I'm quite excited to see Pedro. I can see you with your pharmacy behind you. This is pleasing me a lot, because I had some money, and I thought it's going to be the doctors that are going to be amazing, because I hear a lot about oncologists. I don't know if there are any oncologists on the call, but they do quite niche research. It's quite difficult. Their job's quite hard. It's all, it's all about the little cells and all this. And I was I was quite blown away. And I went through everyone's CV, but actually what was surprisingly impressive to me was that the allied healthcare professional CVs were amazing. And so many people had masters. It was really difficult to choose. But in the end, we've sort of recruited about 24 people, but I still went into it thinking, I'm not sure what a dietitian is going to bring to my cancer centre. I mean, I get that we need to feed children with cancer. I get that. But man alive, the quality of input from the allied healthcare professionals has been absolutely phenomenal. For example, we started off, there's a bit of a roar there in the background. That might be Arvind. I'm not sure if that's you. I don't know. Oh, that's better. I thought it would be the doctors, but actually, so our children with cancer, I didn't know this, you may all know this, the outcomes for childhood cancer are actually very good these days. So it's still a really frightening thing to have, but most children survive to adulthood. So now we're kind of looking to push the boundaries and improve quality of life. What I didn't realise is that children with cancer lose physical condition from diagnosis. So even though most children survive childhood leukemia, they go on to have increasing rates of obesity. They've got poor exercise tolerance, even though their disease is cured. So our kind of physio and allied healthcare professionals and OTs completely reframed this for us all. So we've now kind of all bought into this vision, which is about research and is about being the best children's cancer hospital in the world, but also it's about making sure every child has education, so there'll be a school in there. It's about making sure they're active from the moment they step into the building. So I guess what I'm saying to you is, it's very easy to have a very medical model of things, and I haven't mentioned the pharmacists, but also they've also been fundamentally amazing in how we look at not just, think it's about giving out pills, but children actually don't take their pills very well. So they want to have a children's pill school where they can formulate the tablets so that the children will take them and then teach them how to take them. So there's so much you can do when you start thinking about it from not an entirely medical model. So that's just a kind of point I wanted, because I know you've got a very multidisciplinary team, but I cannot reinforce how important I think that is when you're coming to look at the building, and I guess it sort of dovetails with the ward rounds. The next thing I'm just going to mention is about using the building as a strategic tool. So if you look, so healthcare is high risk, right? We know that. In anaesthetics, we really know it's high risk. But I think all aspects of healthcare are high risk, from making mistakes in giving out medicines, reading them, to placing tubes in the wrong place, to misdiagnosing. It's a whole range of risk that we're exposed to. And we don't really think about how the building can help us that much. So if you look at Google or Apple, they have, the risk is that they couldn't make as big a profit. It's a risk for them, and it's a big thing, right? So they have a building that absolutely is tailored to encourage innovation and mixing of people. They have unisex toilets, they have rest spaces. They're all about getting people out of their silos and working together to cross-pollinate. They accept failure of ideas, but they absolutely want this cross-pollination of ideas. And I don't think that we really think in healthcare how we can do that. Even McDonald's, you go into McDonald's, you have your burger, then you have your hot apple pie. And by the end of that, you're feeling a little bit uncomfortable on the seat, because the seat's designed to be a bit uncomfortable. So once you've had that, you don't stay and chat. You don't think, I'm going to sit and do my working from McDonald's. You pack up and you get out, and they can get the next customer in. But in healthcare, we don't think about this at all, in my view, or at least not as much as we should. There are sort of various things that guide hospital buildings, which some of you might have heard of, which are things called health technical memoranda and health building notes, which are very dry documents, which are not ambitious, which involve a lot of infection control and are sort of to take away risk, but they also really, really stifle innovation. So I reckon that all of you on this panel, like you said, I think it was on the first Mentimeter slide, you weren't entirely satisfied with your environment. I bet all of you have got an idea about what you could do that would make it better. And yet we sort of don't give people the tools to do it. We don't need an architect to tell us a lot of this stuff, but we could work more collaboratively with them to do it. So if you ask, and I have asked the people who design buildings, have they been in them? They'll tell you how a building has to be designed. I was in a meeting a few years ago where the lead architect from one of the very, very big healthcare firms was talking about how to design an operating theatre. And I sort of asked him, so have you been in an operating theatre after you've built it? Because often you'll see beautiful pictures of the hospital with no one in it. And he said, well, I have been in one when my daughter was born. So that was the only time he'd ever interacted with an operating theatre. And you'll find that design teams won't have been on ward rounds largely. So they're not feeling your pain around often things like noise, temperature control. 150 minutes in, most of you are going to be feeling a bit hot. Most of you can't open a window. We haven't even, there's a whole other side to this around sort of COVID ventilation and what that should look like. And we sort of just accept that we're just going to build the same thing again and again. The other thing we should just probably talk about is money. So it always seems quite frightening amounts of money to get involved in a building project. So there's Boris's HIP schemes, which I think Yeovil might be on the list for, actually. £3.6 billion of funding to build 14 new hospitals. I don't think it's going to be enough, but there's obviously this kind of thing about building. It's just a sort of London-centric example. In 2012, the Royal London Hospital opened in Whitechapel, new version of. It cost £1.2 billion, which is like a lot of money. And you think, oh, that's a lot of money. That's a lot of money for the taxpayer. I don't know if any of you have ever been there. I think, Andrew, you've probably been in there. The lifts are quite difficult to work. There's a sort of minor criticism of it. It's not amazing. Not only did it cost £1.2 billion to build, it costs £120 million in mortgage every year. So when we think, and I know Nicola and I have sort of discussed this a little, but you've got nursing shortages, and this is mentioned in your documents as well. If you're paying a mortgage of £120 million every year, that's quite a lot of nurses you can't employ before you've actually gone anywhere. And I think as clinicians, physicians, pharmacists, everyone, we've kind of got a bit of a responsibility to get involved and call these things out, because we're not stupid. It's not really any more difficult than getting a mortgage. It's the same maths, it all works the same. And if we don't sort of take an interest in this, then who is going to be taking an interest in it? What else did I want to say? I think so kind of drawing parallels with your ward rounds and building projects. What building projects do is they give you a massive opportunity to focus on the future, and I think and which is one reason I would really encourage you to get involved. I've often felt quite guilty about asking people to get involved in building projects, and maybe it's the same with this ward round project. And I said to one of our matrons who's very busy, I said, oh my God, I feel really bad. You've had to do this presentation. It's taken loads of your time and I feel terrible. And she said, actually, I spend my whole life firefighting. This is the only chance I've had in my career to really look to the future and to really plan how things could be different, which I thought was I felt encouraged after that. So that was good. And just another thing, just to say, you probably won't see the direct parallels, but buildings are really powerful things. And Churchill, who is obviously Boris does like, so it's like I feel slightly difficult bringing him up, but there was a plan to rebuild the Houses of Parliament after it was bombed. And the architect said, let's make it bigger, let's create a seat for every MP. And he said, no, I don't want that. I want it that if you want to change sides or you want to leave, you have to walk across the floor in plain view. There are only 427 seats in there for 646 MPs. So he kind of was using the physical infrastructure of the building to keep tension in meetings. And I guess you're looking at doing the opposite kind of thing with your ward round. You don't want tension, you want inclusive spaces with a flat hierarchy. But it's an interesting thing about how you can use the building strategically. So I'm just going to look and see how much time we've got. So I've done about 15 minutes. I think I'm very interested to hear from Zubair about the app you're using. That sounds very cool. There are other technologies as well around sort of sound things that we could use, but we need to know that we need to do it. So I'm finished and I shall hand over to you, Zubair. Thank you very much.
Emma, thanks very much. I'll bring Zubair in a second, but thank you, Emma. That's really helpful. You've touched on a number of sort of big ticket items that I think we can explore further with yourself and the clinical reference group, if that's okay. So thank you very much indeed. Zubair.
Yeah, okay. I'll try and share my slides first. I hope everything works. Thank you for this opportunity. I'm sure there are people in the group that are much more qualified than I am, but I shall do my best. As usual, it's taking a wee bit longer for the slides to. Can we all see my screen?
It's coming through, I think. Yep, we're on.
Yeah, okay. So it's just one slide. As I was introduced, I'm a gastroenterologist, been in the business for over 20 years. Got interested in safety and quality, and been running QI projects for a while. We identified a few areas of concern, and ward round and the way they are conducted has been an interest of mine for a very long time. And a few areas of concern and challenges, we thought we'll try to make some changes. So going through the main 4 areas that we concentrated on, the first is noise level. This has been an area that I've been quite conscious about. I believe, and it's supported by data, that a level of noise above, a particular level above which your cognitive function gets affected. And this is relevant in terms of decision making of such importance in a ward round. Now, I don't know if you're aware that WHO set standards of clinical areas noise between 30 and 40 decibels. And it won't be a surprise to you that a survey in particular surgical wards gave an average of 85 to 90 decibels, which is approximately 3 times the level recommended by WHO. And so I felt that this is an area to concentrate on as a first thing to improve the quality of the ward round. So a long discussion and quite a laborious process of convincing people to keep it quiet. I took my ward staff into confidence and showed them data, and then decided to find an electronic solution. So I went on the App Store and downloaded a free app which calculates decibels. It gives you an average. It compares the noise to other noises, like a factory or a bird song, whatever. And I started taking that with me on my ward round, and each time the decibels went up, the staff accompanying me would go and ask people to quiet down or shut doors to make sure. Well, that took a long time. Eventually, we've incorporated it, and now ward rounds are fairly quiet, and spot checks of decibels give around about 40 to 50, which is much, much better. It's the app I've got is a sound meter. I wanted to have a display on the ward, but didn't quite get there, but used my phone with the ward round trolley to make people aware of the noise. So it has worked, and the ward round's much quieter, a lot of time to think, and the only conversation in the bay is between myself and the patient. The second point about information decision making, well, ward round is a combination of information gathering and then making a decision on that information. And if that's incorrect or incomplete, then the decision making is affected. So in order to involve the junior staff in gathering information, we decided that they will come an hour or so before the ward round, prepare the information. And that resulted in 2 things. One, that the junior doctors were completely aware of the patient, so any decisions making about that patient, influence their education. And also they were able to finish their work well in time to do other things like talking to relatives or preparing for the next day, etc. So that has helped. And so we staggered the ward teams. One team would start early one day, and the next team would start early the next day, and sort of made quite a bit of difference. And obviously, this was agreed by the junior doctors, keeping in view their working time directive, etc. The third issue I always believe is communication with relatives, which is root of most complaints, either inaccurate information given to them or incomplete or even conflicting information sometimes. And I thought of a way that at least a consultant ward round documentation is stored somewhere electronically, which can not only be accessed by the nursing staff, but if relatives want to access it, they can access it. Or especially when on-call doctors come and review a patient who's unwell out of hours, they can access the information and get a rundown of exactly what's going on. So we use a tracker for electronic patient record. We're still using handwritten case notes. We are trialing out a few voice recognition software, so this can be dictated either during or at the end of the ward round. So we are in the process of getting that sorted out. The fourth point is standardization of documentation. There is a Royal College standard of how a ward round should be documented. And this is now part of a QI project that one of the F1 doctors is doing. We've included teaching of how to document in a ward round what aspects of patient care needs to be in, especially a consultant ward round. And this is now part of our induction program. So these are the few areas that I identified over the years as needing improvement to eventually improve the quality of my ward round. Few I've achieved, a few have been a struggle, and the others I hope I can achieve in the near future. Thank you very much.
Zubair, thank you so much for sharing your experience. Lovely to see the claps going up. I wish I knew how to do that, but I don't know if you can see those on your screen, Zubair, but there is a virtual round of applause all round. So that's lovely to see. Thank you all very much. So two very different presentations, but really key to the discussion today. So what I'm going to do is bring in both our speakers, but also the clinical reference group, if that's okay. Can I ask, I've been monitoring the chat, but if any of the anyone on the call has anything specific they'd like to ask, or even general that they'd like to ask, please do put it in the chat box so that we can bring that to our clinical reference group. So I'm going to start off, if I may, picking up a point that Emma. Oh, I'm gonna start off by not picking up any points. I'm going to start off by inviting Lynn to comment because she's put her hand up. Lynn.
Sorry, it was actually a mistake. but if I may,
yes, please.
One of the things that really struck me from Emma's talk, thank you very much for that, was the real parallel between you saying, you know, clinicians are very rarely involved in building design, etc., etc., and yet, you know, you're working in it day in, day out, and the parallel between actually patients being involved in these decisions as well. So that was I've just taken advantage of my mistake to put that one in. Thank you.
Well, so can I thank you, Lynn? So can I add to that and then bring Emma in, if that's okay? Because my understanding is that there is quite a lot of work in certain areas. So, for example, in hospice care and possibly paediatrics, I don't know, but certainly in hospice care there has been quite a lot of patient engagement, and I know the King's Fund have done some work specifically around the healing environment, which was heavily involved in patients, but I'm not familiar with that being used for some more general medical, general clinical areas. So Emma, do you want to comment on that, and I'll bring Pedro in, if that's okay. I think you're unmuted.
Yes, I am.
You're unmuted now.
Can you hear me?
Yeah, all good. If we're having technical problems, Emma, what I'll do is I'll bring you back. I'll bring Pedro in and then bring you back in, if that's okay. Pedro?
Yep. Hello, everyone. No, it's just actually picked up on what Emma was talking about, is when she did a parallel between the medical professions and the buildings, is we at the present are the result of decades and centuries of trial and error experimenting, and one makes one mistake and the other one learns from it. The example that you give is that £1 billion hospital. You can't just pretend it didn't happen. You cannot just take that away. You have to live with that. I think that is part and parcel of buildings, and we've been building buildings from, hey, you could recognize buildings built on the Stone Age that or at least the Iron Age, that could be used these days. So the overall concept hasn't probably evolved the same as our professions. And my question is, do you know if there is some kind of modeling or any prototyping, any experimenting before we actually build a building and try it first before we spend £1 billion that we can get rid of?
Yeah, well, so that's a really good question. I couldn't unmute before for some reason. My Mac doesn't like Teams very much. So Lynn, it's really interesting about your patient thing, and I could talk to you about that as all day. And Pedro, what you're saying is really, really interesting. So every public sector building in the UK by law should have what's called a post-occupancy evaluation done on it, which is hit and miss, and it unfortunately doesn't happen. So it's completely fine to make mistakes. We all make mistakes. It's totally and utterly fine. What's not okay, I think, is to make millions and billions of pounds worth of mistakes and then repeat them in another hospital. And so there's so much that you can all do if you get involved, because actually these post-occupancy evaluations aren't done well. They're done often to look at some functional aspects of the building and how it performs against some environmental standards, but they're very, very rarely done to look at how it enhances patient care. So we could spend £1 billion and they might say in the business case it's going to decrease infection rates. No one will ever go back and look at what the C. diff or COVID or anything rates are and how the building has affected transmission. So it's complex to do it, but if you plan to do it, you can do it afterwards. So I guess that's one thing. And the other thing to say just on what can you decide what you're going to do before? Yes, you can. The technology is very clearly there. That every public sector building in the UK has to use a thing now since 2016 called BIM, which is Building Information Modelling. So you should have a very good 3D representation of your building, which can be done in as much detail as you want. So you can walk through it however you want. But as clients, which is us, we need to be demanding that we need that, because it costs a bit of money, not very much, but we need to be the ones pushing that, because otherwise it's much easier and cheaper for contractors who operate on very small margins to say, no, we're just going to build you what we've always built you. We know best. So yes, thank you.
Thanks, Emma, and thanks, Pedro. I mean, I guess a reflection is, ironically, most medical wards do pretty similar things, and it'd be awful if they all look the same, wouldn't it? But there is some element that's slightly frustrating, that you can go into the clinical preparation room that contains the same equipment, the venipuncture kits and the wound packs, and they're all higgledy-piggledy all over the show. I don't quite know the answer from a design perspective. And just to comment about the Royal London, because I was involved in that and some of the clinical design around it, one of the challenges to these big infrastructure projects is that the buildings, the design was signed off 6 years before the building opened, and you know, opened in 2012, and the healthcare landscape in London in 2006 looked completely different. You know, we were planning to move most healthcare to out of hospitals and into the community, and so there is a real challenge in that time lag. So Zubair, can I bring you in if I may, because the improvements you've made and led have been as it were, in spite of the environment. You've got the set structure is there in place. So what were the things that you found helpful or challenging around that? And also, did you involve, I presume the MDT were involved in those sort of innovations and changes?
The issue is, like Emma was saying, we're given a structure, and the way we function has to be adopted to the environment. So when I joined the hospital, everything was in place, and there are certain areas that we struggle with. For example, especially after the ward round, to order results or order scans or whatever else that junior doctors have to do, and a space for them to work without being interrupted, sitting at the nursing station. So with the help of the fire department, who obviously are very concerned that I don't put tables and chairs in the way of the fire exits, we created a so-called corner for the doctors, which doesn't quite obstruct any of the passages, and I got the IT involved in getting a computer and a chair there. So that's worked quite nicely. They're tucked in a corner to do their work. So it was within the design of the building, that little corner that we just thought was ideal, and we just made it happen. But it is a working environment. It is challenging. Talking about I think you were talking about the twin bin system and the catheters and equipment, etc. We did a QI project to standardize all our twin bins in the hospital, including theaters. So you go to any of these stores, they are designed and equipment laid down exactly the same way, which is part of our QI project.
Great, thank you very much, Zubair. I have to say we've tried the same, just hasn't been sustained. It tends to be it exists and it tends to be the junior doctors and some of the junior nurses who've done it, and some of our pharmacy technicians as well have been great. But as soon as they rotate off the ward, then everything goes back to normal. Gordon's got your hand up.
Yeah, I was thinking that back in about 2010, I designed a new ward round trolley with the notes in drawers rather than hanging vertically, and with 2 shelves out to the side, and that and the top drawer we filled with all the stationery for DNA, CPR, treatment escalation plans, request forms and things, and that allowed us to do the ward round with 1 laptop on top and plenty of space to do sort of side work as well. And if you've got 2 of those trolleys with a freestanding laptop, then one of the doctors could be doing discharge notes whilst we were still conducting the ward round. So I can give you a link to those trolleys. They're about £700 each and paid for themselves in 5 days. In terms of
that's great.
In terms of time released.
And just to make it clear that it's not Gordon's personal company that provides the trolleys, just to clarify that. Nikki, can I bring you in, because you made an interesting comment about your experience of noise in intensive care, and I just share a quick analogy with everyone. So I do some amateur music, and I know some of the conductors in the Marines School of Music, and when they're doing the sort of background music for state events, the music goes out the window. There's a green light and a red light, and some of the royal household control the volume. Just on a green light means play a bit loud, and a red light means you're playing too loud, shut up. So it sounds like you had a similar sort of system in place in intensive care, is that right?
To be able to have that amount of control, that would be fantastic, but sadly not. I think with it, we did some studies, and these were some years ago, around the listening ear that had come from the paediatric and neonatal units. And there were really good, simple pieces of kit that you could plug in that were visual, so that people could actually see when the levels reached a preset level and the hertz were there, so that we could reduce the noise. But I think, I mean, that was a really, really good way. Technology has obviously moved on, and there are lots of ways to look at that now. But just from a pure visual perspective, that managed to get everybody's attention on a ward round, and also when we were delivering day-to-day care, to recognise that actually the noise goes around us and increases sometimes without us even recognising, because we're so engrossed in the delivery of care at that particular time.
Brilliant, thanks, Nikki. That's great. So a couple of key points we've identified so far. One is that actually, from the work that Zubair and Gordon have both highlighted, actually there is quite a lot that we can do in our own space and environments, and looking differently and using what we have differently. And secondly, a lot of this is in our own control. So the issue around noise was really about raising awareness and then reflecting back to people so that they change the noise level themselves. Nikki, your hand's up again.
I think I absolutely agree there. Thank you, Andrew. There's a great deal of expertise, and Emma's the expert around this area, around sort of architectural designs and looking at these in hospital designs. But in the current climate and where we are at the present time, there are some simplistic areas of change that we can undertake around ward rounds that will make an enormous difference to our patients, an enormous difference to our delivery. You can see here that some of those have already been implemented, making sure that we haven't got 2 rounds going on at the same time with competing noise levels, not standing behind computers, bringing stools along so that we can actually sit and communicate with our patients, face our patients on that level, because some of our patients may be hard of hearing, so that we can have a clear conversation with them and support that with documentation. And these things are really cost-effective ways of improving the ward round.
Brilliant, thanks, Nikki. And David's put in the comment in the chat about alternative ways of communication, noise reducing headphones. We've talked about health inequalities in the ward environment previously on previous discussions with digital inclusion and exclusion. We'll have more on that in our next learning event with the Patient Carer Network. So we'll, if people wouldn't mind parking that idea, and we can explore that later on. John, can I bring you in if that's okay? I'm going to ask a very specific question, because I know this is something you've had experience of. In COVID-19, we really had to change the way we were working as an MDT and make it not face-to-face. Were there any sort of areas of best practice or examples that you can think of that may well endure beyond on COVID-19 that people could think about?
Yeah, sure. Thanks very much. And absolutely, the way we interacted with social distancing, etc., in wards, it's just a real challenge for many people. So actually, in my own organisation, and I've been on the wards this morning, and we finish on every ward with a virtual multidisciplinary team, because what we found when we were trying to do this more reliably during COVID-19 is that actually our multidisciplinary spaces were not big enough for social distancing and that. So we started to have teams-based post-ward round MDTs, and they continue to today. And in fact, this week in my own trust, we've got a real emphasis on getting those more reliable. So I left the ward at 20 to 12, went down to my office, and then was in the call, as were a number of the MDT members who cover a number of wards and may have functions that help patient care across a number of wards. So we are able to have about 10 people on the post-ward round MDT, no more than 3 of them in any one office at the time, and often spread around. And so that was something that happened during COVID-19, and it has really made a big difference to information sharing, decision making, planning, and following that through. I think other people have found better ways of documentation and sharing documentation during COVID-19 that might not be in the same physical space, but using electronic means more. And I think the final one, again, we'll touch on with patient and carers, but is that communication at the bedside with the family member through the tablet or through the smartphone, so you're having a 3-way conversation, and sometimes with the GP or the specialist instead of the family member. I think those are things that will endure.
John, thanks very much. I really appreciate everyone's time and input today. So John, Nikki, Emma and myself were fortunate enough to be part of a panel discussion last week at a healthcare design conference. I don't know about others, but I've definitely had a huge sense of imposter syndrome. But the conversation felt like it was just the beginning, and we had to end, and it feels a bit like that today. So I'm aware of the time. We have one last Mentimeter question that I'd like to put up in a second, Nick, if that's okay. But before we do that, I'd just like to thank everyone for attending today. I'd like to thank Emma and Zubair for their presentations. I'd like to thank everyone on the clinical reference group and everyone who's contributed in the chat and just by being with us. I think this is the beginning of a conversation. What I'd like to do is with the clinical reference group, we'll take some of these conversations forward in the form of a blog or something and share that with everyone, and hope that people can join in the debate, because I feel this is an area that we could continue discussing. So on behalf of everyone, thank you very much indeed. We've got one last question to ask Nick, and I wish you all a good afternoon. So Nick, over to you, please.
Thanks, Andrew. I'm just updating the slide just so you can get the QR code back again. So I'm just going to share again now with you. So if you've logged off already, then you can log back in using your QR code. If you're still on your phones, you've still already got Mentimeter already up, then we can crack straight on. I'll give a few more seconds for people to rejoin if they can. So just one last question. Based on all the things that you've heard today, so I think it's been a really helpful discussion. And there's a few hints and tips out there as well. I mean, you're asking for ideas at the start of the session. I think there are a few things there. I really like Zubair's noise monitoring app. I think if that constantly reinforces that question, as he found, then you start to reinforce those behaviours as well, and sort of get into a bit of a habit. So anyway, so one last question for today. So out of all the things you've heard today, and a really rich discussion from our guests, and again, thank you very much for that. What's the one thing that you can take away from today that you can take back to your ward environment, possibly this afternoon, if you're going back onto your ward this afternoon? But if not this afternoon, what about tomorrow morning? What's the first thing that you can take back? Yeah, improving noise levels. I think those stats around the decibel levels are quite startling, really. Think about what they should be and what they actually are. Just measuring in your own environment, that would be a really helpful thing to do. Gordon's popped the link to his ward round trolley in the chat. I'm obviously not his ward round trolley, although Gordon, that may be a little bit of a sideline coming up for you in the future. I'll have a chat with you after about that.
Other trolleys from other black brands are available.
Yeah, not as good as Gordon's though. Made the most of the estate. I think this is really difficult. And I think one of the things I've heard time and time again today, and generally, is just try something. This often can be seen as too big and out of your hands. It's somebody else's. It's the estate department, or it's other people's issue. But you can do small things, as Gordon described and Nicola and others have described. There are small things that you can do in your own environment. So this is what makes a difference. Not waiting for big design projects to kick in. It's some of that small stuff. Brilliant. So we've got a load of response then. I'll pull these together, and these will come out on a bit of a PDF, and I'll circulate these videos so you've got them anyway, and you can refer back to them and maybe take them back to your work environment. Andrew, back to you.
Lovely, thank you very much, Nick. So we're going to wrap up on time. Our next clinical learning event, there will be a date change, so apologies in advance, but the date I think will be the 22nd of July, not the 28th as advertised. Details to follow. We have the next QI learning event as well, and you should have some dates in the diary with your coaches coming up in the next week or so. Thank you once again for everyone who's participated, presented and spoke. Thank you all for attending. One of the requests at the beginning of the session was to be inspired and to be happy, and I've certainly been inspired by the conversations today and feel very happy with everything that's going on. So thank you all for all your improvement work. Have a great afternoon, and we look forward to seeing you all soon. Take care, everyone. Bye now.